we start from the bottom? Okay, so I think that's an excellent question. What is the anticoagulation strategy post-MACE procedure? And let's start, Steve. What's yours for standalone?
So it's a great question, and the answer is it depends. All politics are local, and to be honest with you, it depends on I think the education that you have provided your internists and electrophysiologists with regard to stroke risk post-MACE and with a ligated left atrial appendage. My typical strategy is I keep patients on anticoagulation and antiarrhythmics for at least the blanking period, so 90 days. And they'll look at me like, well, I just had this big procedure for AFib, why do I got to be back on medicines? And it's a really matter of education about the fact that it's the scar that we create from ablation and not the ablation procedure itself that, ablates these lines. So at the end of the blanking period, if those patients are no longer appear to have an AFib burden, then I'll stop their antiarrhythmics and leave them on anticoagulation for a period of time, depending on what antiarrhythmic they're washing out. They're washing out amio, that may take 2 or 3 months, depending on how big they are. If they're on a drug that's shorter acting, then it may be a month. And if I can monitor them rigorously and show that they have no AFib burden off antiarrhythmics for a period of time, I believe that's the point that they can have their anticoagulation discontinued. So that's the protocol we've used.
Sam?
Actually, that's my question. I wrote it prompted by my PA, McKinsey.
Okay.
I wanted to bring up the fact that we've been doing some of these, what the EPs call single shot ablations, the simultaneous hybrids. And I'm very intrigued by the fact that they are extremely religious about anticoagulation because they form char and clot inside. And they actually, if I left it to them, they would start heparin the night of surgery. And I don't know of any surgeon who does that for a lone AFib procedure because they're very worried about the endocardial ablation lesions.
So in the same day hybrids that we did that for everybody, which is, it is a difficult thing to get a surgeon to anticoagulate their patient the night of surgery. But you're right, that if you watch what they do, I'd be scared too.
Right. But we do endocardial ablations with, I guess we're using cryo, but in the days when we were using radiofrequency, it was also an endocardial lesion. We were creating the substrate for potential clot formation, yet I don't think any of us really thought too hard about putting somebody on heparin after you'd open their chest or done surgery on them.
Yeah, so I think this is an extremely important question for various reasons, and also a guidelines challenged question, because there are no guidelines that we can come with to guide us. So I can echo what Steve said and what Sam said, but I would add a couple of more points that guide me in the decision how to stop or when to stop anticoagulation. So we anticoagulate all patients, regardless of the energy source, probably up to about 6 months, because if you stop the antiarrhythmic drugs at 3 months, I want to allow at least 6 weeks off it, and as you know, in clinic it's not always like a computer, so 6 weeks, 3 months become 4 months sometimes, and so on and so forth. So 6 months, we are calling all the patients for Holter, and if they are fine, they are candidates to stop anticoagulation regardless the chart score. However, we are very religious about the echo. So there are a few points with the echo that are important. One is how complete and sustainable is the left atrial appendage exclusion or whatever you excised. Certainly, what's the quality of the flow within the left atrium? If you have echogenic flow, meaning in patients with low EF, severe diastolic dysfunction, sometimes even maybe extreme LA dysfunction, then I would never stop Coumadin. There is a paper in JACC in 2012 that actually showed 50% stroke rate when they ignored the echogenicity of the smoke and in patients with predominantly were rheumatic heart disease patients. So I think if the echo is okay and the patient is in sinus rhythm, it's okay to stop anticoagulation. or at least we need to have a new paradigm outside the CHAD score, because as you saw with our papers, with 2 studies, there's more risk of bleeding than risk of stroke following that. So I would urge everyone to have echo as a part of your decision. So, well, that's a little outside the talks, but when should concomitant ablation be done? Do you want me to 2 minutes about the guidelines? Okay, well, so what the guidelines, the STS AATS guidelines showed is basically, for the first time we showed level A, class 1, that ablation procedure concomitantly improves 30 days outcome. Survival is higher. Second, no increase of complication. Those are the AATS guidelines. The STS guidelines have level A class 1 indication for mitral valve, and 2A for aortic and CABG. And also the type of procedure, they said, if it's a moderate to severe MR, for instance, persistent oxygen persistent, should be a MACE procedure and a unilateral lesion set. So with that being said, the vast majority of patients should be ablated. But the problem is that this is not the reality. The reality is about 45% in the US, 60-some% for mitrals, and 30 or less for CABG and AVRs. So if we step outside the guidelines and look at each one of us and say what makes you to decide to do it or not, I think it's your decision. I mean, I'm not going, it's based on your experience and so on and so forth. So my own perspective, the patients I'm worried about are those with RV dysfunction, other comorbidities that you don't want to extend surgery, even not in a minute, and patients that you definitely know that ablating AF is not going to help them in terms of quality of life and longevity. So with that being said, what we also have in the guidelines, the SCS guidelines, which say that basically if you decide not to do the ablation, the least you should do is exclude the left atrial appendage. What I don't understand is how some surgeons go into an AF case, they decide not to do an ablation, which is fine. I said it's legitimate as long as you base it on your own experience. You want to be safe, but you leave the appendage alone. That should not happen.
I think the question should be, when should a concomitant ablation not be done? I think that should be the list of non-indications. For example, what's the size of a left atrium and a right atrium, for that matter, that you would stay away from? And I know you have an opinion about that because you've published. And the second one is, how many episodes of paroxysmal pre-op would you accept? The patient, for example, that goes into AFib in the holding area and that's their first time. Is that somebody you would ablate? Would you take the appendage? Those kinds of questions sometimes pop up that people don't know the answer to.
Well, I can answer. So I think any given size of left atrium is, if you do something right versus not, you're going to have some success. And we published a paper, it's a well-quoted paper, that showed that even with 8.5 centimeter left atrium, you have success rate of about 60% at 5 years. So that's better than 0. But the reality is that we almost never see those atria anymore, because patients are being referred earlier. So I think it's becoming more and more of a theoretical question. As what to do with a patient with paroxysmal first time in the holding area, that's an excellent question, because how do you know it's the first time? You don't know. So
first time documented.
Yeah, so it's a big issue, because you have to remember the guidelines say that you have to treat only symptomatic AF. Now, symptomatic not necessarily have to be palpitation, it's shortness of breath, strokes, etc., but that's the issue. But the least I would do with a patient, I would not do a MACE procedure probably on this patient, but I would exclude the left atrial appendage.
I agree.
Can we take on the top question there for Steve, because you've done this several places?
Yeah, so that's a hard one. My EPs just don't believe the data, and they don't think there's a role for surgery, maybe even in catheter ablation for AFib. What do you do about it? We have done a lot of different things. We've gone to places, and I've actually gone to places with my EPs and given talks and presented data and that sort of thing, and sometimes that helps, but most of the time it doesn't. I believe that there's a certain, for whatever reason, there's a certain resistance that you may not be able to overcome. I think that ultimately, the best thing that we can do is to continue to generate good data to show that scientifically this is something that, AFib is a dangerous, mortal disease. People die from it, and it complicates cardiac pathology across the board, and that we have a procedure for it that is maybe not 100% effective, but generally extremely effective if used appropriately, and that, once intervened on, the patients have a reduced morbidity mortality down the line. So it's on us to generate the data that's going to make that easier to answer for surgeons trying to develop programs and that sort of thing. And I think things like taking that data and putting it into guidelines, as Dr. Ad has done and that sort of thing, is an important step. So I think that's probably the best way that you're going to do it, is just to ultimately come up with enough data to overcome that resistance.
Yeah, I think I agree with everything was said, but I think I could give you a couple of advice that I think are important. One, if you will focus on the technical aspects of the procedure, that you can do it with a 1 hole, 2 holes, 3 holes, 4 holes, mixed anatomy, whatever, you're going to fail 100% of the time. Because, as I always say, the EPs have a different definition for a double-blind study. For them, a double-blind study is 2 cardiac surgeons looking at EKG, So you have to understand that. They think we are morons when it comes to AFib, and most of the time, they are right. Most of the time, they are right. So the first thing you have to do is to convince them that you are not there just for the case and the RVU, is basically you want to establish serious. And that's a process, and it takes time, and it takes some dedication. The second thing, everybody's going after the standalone, but the low-hanging fruit is the concomitant. So often I go to places and the EP is saying to me, yeah, he wants me to start to send him patients, but he gets 100 mitral a year with AFib and he does 0. So why should I send standalone? So start to develop those relationships around the patients you already have, that are coming to surgery, and do a good job there and communicate with your EPs. You call the EPs to the operating room when you do a bilateral pulmonary vein isolation part of the maze with a clamp, and you ask them to help you to assess the block. So you introduce them into the surgical arena, which they are completely blinded to, as a process. And so you have the EPs in the operating room one time after the other, helping you to assess exit block, whatever in the post-op care, and so on and so forth. And I think this way, you can create some type of common grounds, and you can talk with them about it. Otherwise, it's not going to happen.
Can I just add as well that the majority of EPs that I meet and I talk to, they are very, very interested to talk to a surgeon who has knowledge about atrial fibrillation. And they're very intrigued and excited and surprised when they find such a person. And they also like to hear the word minimally invasive. And when you say that you can partner with them minimally invasively, not only on their AFibs, but also on their VTAC, and on their lead extractions, and on anything and everything they do, you become a really, really good friend and a resource, and you'll be in their hybrid rooms more frequently than maybe you would like to be. And I think the relationship is much, much deeper than just AFib with EP.
I have 2 questions, and they're sort of related. Dr. Cox has said that recurrences of AFib in the initial postoperative period are common, and that's bin part of my experience. So, 1, what is your strategy for antiarrhythmic drugs after the maze? And then 2, there appear to be some patients who benefit from some long-term substrate modification by continuing on some homeopathic dose of drugs. Do you have any feel for who those people are, how you identify them preoperatively?
Yeah, those are 2 excellent questions. You want to? Yeah.
So post-procedure antiarrhythmic therapy, I usually try to have them on class 1 or class 3 drug. A lot of them, if I'm lucky, they'll come in on a beta blocker. Amiodarone is my drug of choice. There's a lot of resistance that I see in various places to real antiarrhythmic therapy, real class 3 drugs. But I think if the goal is to have them on them short term, you very rarely see the long-term side effects that people are worried about. But short of amio, I've used Sodalol not uncommonly for its pharmacologic, or the pharmacologic benefits of it, and to a lesser extent, Fleck or something else. So that's what I would use on the short-term basis. Do you have a different?
I generally will start them back on the medications that they came in on.
Yeah, so we have a prospective randomized study on that we published, I think presented at AATS the year before the last, showing that amio for 3 months is benefit. It's a huge benefit, much less recurrences. We are not that smart. It's based also on the EP literature that show the same. So the more you have the patients on antiarrhythmic drugs, regardless the rhythm at discharge, it's better and less events. But it brings your second question. It actually is a fascinating question to me. And we have a paper that's right now under review in JACC that I think we are touching that point. And the issue is how important it is, exactly what you said, to modify the remodeling. Maybe we don't know much about reverse remodeling. We don't know what happened if we bring back the patient to sinus rhythm and what happens on the molecular level as much as we want to know. But conceptually, if you keep them, if we say atrial fibrillation begets atrial fibrillation, we may say that sinus rhythm begets sinus rhythm. So now, because of the guidelines and the way they press us that the success is only off medication, sometimes we are being forced to stop the medication all the time just to say, oh, 6 months we have 100% off medication. This is why I think it's a little artificial. So we look at the problem in a different way. And I'll get to the point very quickly because the time is short. If you have a stable sinus rhythm during the first year, okay, meaning that every time point or longitudinal follow-up with the reveal or whatever methods you use, okay, that's the ultimate predictor for 5-year success rate. Stable sinus rhythm at 5 years. The paper was presented at the AATS last year, and now it's under consideration for JACC. This is with 800 patients. That's not with 20 patients. So often, if the patient had a 6-centimeter atrium, they had continuous atrial fibrillation, they are doing extremely well. I would not stop the antiarrhythmic drugs for, let's say, 6 to 9 months. But unfortunately, I don't have exact, cutting point in decision making, but it makes a lot of sense. This is a fascinating question in my mind. So, just one last question. So, about the convergent, who asked it? Huh?
Nobody's owning up.
So let me tell you.
What's the answer
to
the question?
Well, the guidelines would say no. But it doesn't mean that this is specific opinion about convergent. It's about hybrid. It's about that's being done with unidirectional technology, and it's about any of these. That's what the guidelines are saying. Now, it's based on some evidence, but the guidelines are guidelines. It's not something we should live and die by. But the one thing we have to remember that I'm always amazed by that imagine that we were starting to treat mitral valve today. And the companies will come to you and say to you, the ultimate study to test if mitral valve repair is working minimally invasively is mitral clip. This is where we are in the world of atrial fibrillation. Instead of showing that mitral valve repair using the Carpentier technique is working well, and then you move to chords, and then you move to this, to compare to other avenues, we started with a mitral clip, and now we may have to go all the way back, because convergent, some reports are dismal when it comes to success, but very importantly, there is one report in the literature from this state with a very known electrophysiology, Andrea Natale, showing 12.3% mortality. I don't have 12.3% mortality on anything I do, let alone AFib. So we have to be very, very, very careful. So anything you do, you need to have control. You need to have right delivery of endpoints, so we can move this field forward, so we can achieve what Steve predicts, and I think, and rightfully so, that we can achieve the goal of beating heart, minimally invasive procedure sooner than later. But we need to be very, very careful about the steps.
Yeah, the only thing that I'll add to that, I totally agree with that, is that the difficulty with convergent is that it is simple. And in my opinion, the lesion set isn't as rigorous. The inability to manage left atrial appendage is not present, although a great many surgeons that I know, including myself, who have done this convergent procedure are now adding 3-scope left-sided thoracoscopic left atrial appendage ligation to convergent. So that's potentially an improvement. And again, I think it depends on who you're talking about using a convergent procedure for. If you're talking about treating patients who have paroxysmal AFib and have failed a catheter ablation, that may not be an unreasonable thing, that are kind of verging toward persistent. But I think it may be one more arrow in our quiver. But I think it's very early on in the experience, and I think we'll just have to sort of see where it goes.
Yeah, and just before, I know we need to finish, but Dr. Cox was quoted about the future of beating heart surgery and the excellent, what's an excellent procedure, but he always says often, which I agree, if you take Whipple procedure for pancreatic cancer and you look at the results, or esophageal cancer for a different procedure, and you look at the results at 1 year, they look pretty good, but if you look at 5 years, they're all dead. So Lemaire just presented in Europe his results with hybrid procedure. He's the most experienced one, 5-year results. So his sinus rhythm rate is about 70-some%, but if you look by the definition, it's less than 50%. So we are going to be scrutinized about cost, about outcomes, and the biggest risk of this hybrid procedure is that it's not going to be shown more effective than multiple catheter ablation procedure. It's not that it's less good than what I showed. It's obvious that the MACE procedure is better, but we have an obstacle, a psychological obstacle to send patients to this procedure, which is understood. It's that if hybrid procedure, beating heart procedure are not going to be shown more effective than catheter ablation in 5 years, this entire field is dead.
Well, on that note, I think we're going to finish the session. A gloomy note, you might think, but that's not the case, because when you go upstairs, I think you will learn what they have to say. And so my thanks to Niv, Steve, Ralph Damiano in absence, wherever he is, still on this earth. I didn't mean for it to come across that way, but in Atlanta or back home. And of course, Sam for helping with the discussion. Now, before we go up, okay, now, the next thing is you'll be going up for the lab. There are 4 rotations that you will have today. One of those will be atrial fibrillation. The others will be mixed cabbage. The third will be robotic cabbage. And the fourth is something that is sort of a combination of what Teresa Kieser spoke of, which is graft assessment, showing the technical details of how to perform it, the physics behind it, the rationale, and how to interpret it. And that will be in combination with another section to that rotation, which will be in the hybrid room. We have a full hybrid room up over there, where you'll be taught how to operate a hybrid room, and there's a cadaver on there. You'll be shown how to do a lung nodule localization as a way to demonstrate the use of the hybrid room for a surgeon. So those are 4 very interesting rotations. Some of them, for example, the atrial fibrillation and the robotic CABG station, will have more than one faculty. So I would ask you when you go to those stations that you split yourself up and then halfway through switch over. That way you get the experience, and it's not that everybody goes to one faculty member and the other one isn't doing anything. And just as you had yesterday, when you go upstairs, you will have detailed instructions on what to do. We're running a little bit behind, but that doesn't matter. We'll take another, 20, 30 minutes for lunch and getting changed. Even if we get started by 1:30, we will easily finish by 5:15, 5:30, which is what we have allowed for. The faculty, I would ask you to please go upstairs and inspect your stations at the earliest opportunity while the attendees are changing. All of you, please fill out your online evaluations. You have no idea how important this is to us, because we really use it as a guide to help alter and change what we do for you in the future. I'd like to thank all of the faculty, since this is the last opportunity I'll have to, or any of us will have to address us as a group. Thank the residents in particular. I was very, very pleased that we had about 15 residents this year, and reiterate what Dr. McGillivray said about our thanks to Gore for providing the support to bring them in, and we hope this will continue year after year. Thank, of course, all of the attendees over here, but most importantly, close to my heart, to thank the staff who made this possible. Carrie Stein, the AV crew that we've talked about, Brandy and Angie up in the lab, Rose, who's my assistant, who's just given countless hours to this. So I'd like you to give them all a big round of applause, please. Okay, let's get some food and then we'll go upstairs and get changed.